Hello, everyone. So it is a pleasure for me to be here with you today to launch our fourth speaker in our series, Interdisciplinary Perspectives on Learning, organized in collaboration with the Center for the Study of Learning and Performance, CSLP, at Concordia University, and with McGill University. My name is Mayra Saint-Laurent, postdoctoral fellow and member of the CSLP. I will begin by acknowledging that Concordia University is located on Indigenous lands. Montreal is historically known as a gathering place for many First Nations. Today, it is home of a diverse population of Indigenous and other peoples. We respect the continued connection with the past, present, and future in our ongoing relationships with Indigenous and other peoples within the Montreal community. I will now give you a small introduction about the CSLP. So the mission of the CSLP at Concordia University is to research teaching and learning processes. We currently have about 45 faculty members and various undergraduate and graduate student members who have developed unique pedagogical expertise working with community organizations, school boards, policymaking bodies, and social health service providers. Our center's overall focus is to develop evidence-based tools and strategies that would positively impact our society. One of the center's one of the center's development priorities is to support the transfer of knowledge to practice settings. For us, this speaker series is one way we are hoping to achieve this objective and reach out to several educators, public policy representatives, school counselors, researchers, and administrators of educational institutions. So welcome to all of you. Our presenter today, whom our esteemed CSLP member, Professor Weddington, will introduce in a few minutes, will have 35 minutes for his presentation. A period of questions and answers will follow. So kindly write your questions using the Q&A feature in Zoom. Please indicate if you would like to be called upon to ask your question directly, or otherwise we will be happy to ask it on your behalf. We will try to handle as much as possible, hopefully all of them. The question period should begin as soon as our speaker is done with the presentation. Finally, please note that we are recording the presentation today, and the conference recording will be available on the center's website and social media pages in the coming weeks. So it gives me great pleasure to give the floor now to Professor Weddington to introduce our speaker for today.
Thank you very much, Mayor. All right, so my name's Dave Waddington. I'm Associate Director of the Center for the Study of Learning and Performance, the CSLP. So today we are presenting Stephen Schensul. Professor Schensul is a professor of public health sciences at the University of Connecticut. The first 2 decades of his career focused on health and mental health issues in underserved African American and Hispanic communities in Chicago, Miami, and Hartford, using participatory action research to assist in developing community-run health institutions and programs. The last 3 decades of his work have focused on global research and intervention to prevent and treat HIV in Sri Lanka, Mauritius, and India with funding from the U.S. National Institutes of Health. He is the recipient of numerous awards, including the Career Award from the Society of Medical Anthropology. Now, here at the Center, we're excited about the possibilities of interdisciplinary inquiry into educational challenges, as it is, in fact, the theme of this speaker series. And clearly, judging from the way he has applied anthropological perspectives to public health challenges, we have a lot to learn from Professor Schensul in this regard. I am delighted to welcome him to speak to us here today, and the title of his talk is Cultural Solutions to Collective Problems. So take it away, Stephen.
Well, thank you very much. And let me just start out with a few thank yous. First of all, my colleague and friend and collaborator, Professor Abdul Wahed Meki Barada in the Department of Anthropology at Laval. Unfortunately, he can't be with us since his brother in Morocco passed away. He was our initial project coordinator for our earliest study of HIV in India. I want to thank Professors Waddington and McDonough for extending this information. and to Mayra, to Dr. Mayra St. Laurent, and for her coordination, and Angus Tama, I'm going to mess up this after practicing, Tamovsky, for his technical help. Hopefully that was reasonably close, Angus. My objectives in this presentation, and I think I want to put up my slides, so just tell me if I'm all set. I think I am. So,
oh, sorry, Stephen. It's just Angus here. If you wouldn't mind just sharing the screen, we're not seeing your screen at the moment.
Screen again. Okay, sorry.
Thanks so much. And by the way, did a great job with my name. I know it's a tough one.
No, it should have been a lot easier, but let me just. Sorry for the delay. Share screen. Can you see that?
Perfect. That's excellent, Stephen. Thanks so much.
And I have to go back. Okay, sorry for that. My objectives today are to provide a practical approach to what anthropologists think of as a complex problem, and that is culture. To examine how to build culture into our approaches to the phenomena we study, but also to build it into interventions that will provide cultural solutions. And so I will provide a methodology somewhat before I go into a case study in India that exemplifies this, and then finding an approach, a methodology that I sometimes call systems analysis for your ability and to build that into your programs. I know many of you are in the general field of education and perhaps even in communications, but I want you to think of anytime I mention health or mental health or any of the general public health problems, think education, because for the most part, many of us are independent variable people. We can work on anything in terms of an outcome, but we're really involved in prevention and involved in changing those factors that contribute to negative outcomes. Now, interdisciplinary work is easy to say and hard to do. Someone, colleague of mine, Pat Rosenfeld, talks about transdisciplinary work, in which you're not just simply working side by side, you're not just bringing somebody in as a consultant, but you're forging a common perspective on a particular phenomena and doing it with a full understanding of each of your collaborators' theoretical and methodological perspectives. I'm going to give you perhaps an extreme definition of what 3 different kinds of people that I work with do. First of all, there's the anthropologists, and we're expert at studying culture and describing culture and behavior in diverse contexts and communities. But unfortunately, we rarely translate these results into solving collective problems. And I was mentioning to David that, you know, despite the fact that we've been advocating for applied anthropology for many years, within the context of academic anthropology, things have not changed that much. Then there are the public health professionals, and they're certainly involved in wanting to see systems change and to be involved in those factors that will prevent negative outcomes. But typically from the cultural perspective, they're much more interested in evidence-based interventions that worked in multiple locations and bringing those into local context and rapidly sometimes adapting those evidence-based interventions into something that's more culturally relevant. Typically as well, it's public health professionals that run these large projects. It's relatively rare that anthropologists do it, or even other social scientists, maybe psychologists are also involved. And the medical practitioners, in their most extreme, see every individual body as essentially the same and work on the dependent side, the outcome side. For the most part, less interested in prevention, and this, of course, doesn't apply to a number of types, but less involved in prevention and more involved in doing something to remediate that negative outcome. These are the people that I work with, and it's a job to get everybody on the same page. My work has been typically in these areas that you see. Of course, these days, every public health person and every social scientist, I'm exaggerating, but almost all of them has to deal with COVID-19 in one way or another. And we've been very active in that realm. Another area that I've recently got into, not so recently, but about 4 years ago, is chronic kidney disease of unknown etiology. It's not as a result of diabetes or hypertension, but rather of some environmental impact that we yet don't fully identify. And this is a project we've been working on in a very high endemic area in Sri Lanka, but it's all over the world. The bulk of my work over the last 3 decades has been HIV and STIs, also in mental health, most recently in terms of adolescent girls in India, and then lots of work on maternal and child health. And these are some of the locations in which I've done that work. So I encourage you to think education while I'm thinking health. So what is this concept called culture? In the early 1920s, it turns out that there were 120 definitions of culture. I'm sure that's exponentially expanded, but it's not so much how to define it as what it does. And from my point of view, the first thing is it's shared. And it has to be shared by some substantial group of people. It doesn't, there can be, for example, in the neighborhood I lived in Chicago, there was groups of people who had migrated from Mexico. There were second generation Chicanos that were involved in gangs. There were young people involved in gangs. There were older people building up businesses. And of course, there wasn't a shared, and there was a certain level of shared culture across those groups, but also particular to those groups. But it needs a number of people. It can't be idiosyncratic. It's definitely learned. And depending on where you're growing up and the multiple influences of family and school and community, it also has a significant function. And it's definitely enforced. So if any of you have teenage daughters, you know that if they're wearing the wrong thing to their high school, they're going to get a lot of negative feedback. So that negative feedback kind of shapes individuals both learning and making sure they stay within the norms of that particular group. At the same time, people are involved in multiple cultural systems, so that I had a good friend in Chicago who was expert at being a Chicano gangbanger, while at the same time being able to communicate with his older relatives, while at the same time being involved in general American culture. So we're all a product of multiple cultural systems. And there's culture is also continuous in the sense that there may be elements that are multi-generational or decade long, and they continue into the future. At the same time, culture is very adaptable. There's always new developments, and those have to be, David was describing his work on computer and video games. He wouldn't have started that work. Oh, sorry about that. Harmony, stop. So I must have said the wrong word, and I don't know how to stop it. So there can be internal dynamics that change the relationships. For example, there may be in India, for example, women are part of a new kind of formation of a group over the last 2 decades called Mahila Mandals. And those mandals are beginning to respond to women who are complaining of domestic violence. And so they're able to organize and actually come to the individual household to confront the husband about intimate partner violence. That's very much a kind of internal dynamic that's changing. External pressures include a ban in India on underage marriage, under 18, and that has created a certain dynamic and change in behavior. Then what culture is not, is it's not deterministic. Just because you're a member of a particular group, in the early days of being at the UConn Medical School, I was forced into describing the culture and dynamics of Puerto Ricans. And I talked about one folk illness called empacho. And empacho is a kind of lump in the stomach. So the physicians I was talking to go off, and I come back the next week, and he said, one of the physicians said, you know, what you're telling us, it's just not true. I said, why do you say that? He says, well, I had a patient who described himself as having a big lump in his stomach. And the patient, and so I asked the patient if he had empacho. And the patient said, sorry, I don't believe in that shit. And I tell that story with the view that, yes, there may be, let's say 30 or 40% of Puerto Ricans who believe in and respond to and treat empacho in particular ways, but there are many who are not, but that doesn't obviate the idea that it's part of the cultural framework and a part of the cultural system. Culture is not personality, and that relates back to deterministic. And it's not, as we always make the point in anthropology that there's more intra-cultural variation than cross-cultural variation. But it certainly interacts with personality to produce behavior, as well as all kinds of other things, peer relationships, school relationships, more global and national dynamics and so we think of behavior as a complex interaction which includes culture. And certainly it's not just rituals and customs. Now, what kind of solutions can culture come up with? Well, it can help us with local terminology and concepts like empacho and others that you'll see in a bit. So we're dealing cognitively with a greater understanding, or attempting to achieve a greater understanding of what people think, what they're talking about. Anthropologists are very big into the emic, drawn from emic and etic and phonemic and phonetic in linguistics, understanding the world from the point of view of the resident, the individual, the member of the culture. It can help us engage key stakeholders in the research and intervention process. And towards the end, I'll take a look back at participatory action research and community-based participatory research concepts that have developed over the last 20 or 30 years about partnering with people in the community. And to partner really means to, first of all, have them understand what you're doing, and secondly, to fully engage in that process. Another important one is linking to resident priorities. When we did our work in this community that's coming up, for the most part, nobody could care very much about HIV. It wasn't the rate of HIV in a natural community that didn't necessarily include a focus only on high-risk individuals was relatively low. And so we had to somehow understand what resident priorities were in the context of HIV and sexual health. It helps us in engaging community resources. And one of the things that, as you see on the bottom of this slide, is that we frequently are looking for problems. We're looking for description of structures, but we're not necessarily looking for resources for solutions. And I hope that you can take away from this an approach to doing that. It certainly helps us with logistics and supports and entree into populations. And sometimes it helps us change negative culturally based behaviors into positives. For example, one of the things we encountered in maternal and child health in India was that mother-in-law had a great deal to say about the way in which junior wife brought into the household was accessing perinatal care. And frequently those accessing that was delayed by the mother-in-law from the point of view of her seeing greater advantage in her providing the guidance. Now that's negative, and it ended up delaying individuals into prenatal care or suddenly appearing for delivery. Yet at the same time, it provided somebody who could be communicated with to combine both their perspective on appropriate perinatal behaviors, combined with the use of behaviors that would add to and increase the health of the expectant mother. So I won't spend a whole lot of time on this, except that ethnography is now no longer seen as just qualitative. It includes lots of quantitative analysis, from secondary data down to baseline surveys, and in between lots of observation, participatory observation, in-depth interviewing that continues that effort to understand the world from the perspective of the individual. And I refer you to a compendium of books called the Ethnographer's Toolkit that describes many of these this methodology, edited by Jean J. Schensul, my wife, and Margaret Lecomte, Rowan and Littlefield, and which I've got a book in that. At the same time now, at one time, maybe anthropologists were looking at isolates, but for the most part, nobody is ever isolated. And now we've got global and national dynamics that provide challenges, governmental institutions, so national systems, local institutions, neighborhoods, sub-communities, families and households and individuals. And you want to begin to characterize the cultural elements that emerge from each. For example, we were working on nutrition among adolescent girls in an economically marginal community in India, and finding that they were dieting. Now, why would they be dieting? Well, they had an image of, there was at one point an image of women being substantial in terms of weight as a marker of good health and economic status. Now it's all thin beauty, and as exemplified by Bollywood stars, and despite the fact that they were underweight, they were trying to achieve an image of what's now the appropriate kinds of models for beauty that are characteristic. And similarly, skin lightening has become an extensive process, even in relatively poor communities. So I'm going to describe a program that has lasted over the course of 20 years. And if we get a funding in the most recent, it'll continue on. It's called RISHTA, Research and Intervention in Sexual Health Theory to Action. RISHTA means relationship in Hindi and Urdu, and it's a very nice term. And this particular project that I'm using as an example is prevention of HIV, STI from husband to wife. Although India has a relatively low rate of HIV, it's got such a high population that they're third in terms of the number of cases. And almost all of the women, not all, women who were commercial sex workers were also considered high risk, but most of the infections have proceeded from transmitted from husband to wife. So let me tell you a little bit about these communities. We're talking about an area that's designated as a slum community, an approximate population of 600,000. This community is in the northeastern part of Mumbai. There's considerable variations in both housing and income, and you're seeing an area that's particularly called Kacha, made up of found materials. There is 90% of the people are living in a single room. Income is very variable because most of the men are involved in daily wage work. And very much a deteriorating structure of lots of mud and poor quality in terms of water and infrastructure, roads during the monsoon season, and equivalently dust and heat in the dry season. So we're looking at the focal dependent variable of women's risk of HIV. And some of those independent variables, if I might use that terminology, involve gender inequity and rigid gender roles, lack of women's mobility, literally not able without significant permission and perhaps accompaniment to come out of their houses, intimate partner violence reported frequently, forced and unwanted sex, and all the complexities of having sex in a single room with other family members. Poor husband-wife communication, particularly exacerbated when husbands are not bringing in sufficient income to maintain the household, and women are not getting sufficient income to do their part in maintaining the household. So that contrast and inability to meet ideal cultural norms is affected by their economy and a number of things, including low self-esteem and empowerment. From the point of view of factors, additional factors, we have limited and unstable sources of income. I mentioned that, poor infrastructure, inferior schools, which create real difficulties in women and girls being able to maintain education, frequently denied education when they post-menstruation, post-menarche, when they're required to leave school because they become marriageable. Allopathic care is limited to a municipal hospital and a few practitioners. And then we have an enormous number of what's called Ayush practitioners. That's Ayurveda, yoga, Unani, Siddha, and homeopathy. These are practitioners who are, for the most part, uncredentialed, but they're really the ones delivering care in the community. There's probably only about 10 who are allopathic Western practitioners, and lots of harassment of girls and women. So here we have a model in which we've got a whole series of independent variables affecting greater risk of women getting HIV. And the question is, how do we begin to look for resources that will help us in the development of interventions? So the first of those is, and by the way, resources themselves can be all kinds of things. They can be problems, they can be helping factors, they can provide access. So the first one of these is Safed Pani. Now, Safed Pani is literally translated as white water, but it actually means vaginal I'm trying to find the indigenous term and the way it's translated. But let me just say that it's vaginal discharge, in which this is not a serious problem from Western biomedicine. It's generally benign, but not perceived that way either by the healthcare system and certainly not by the women. They think it's a very serious problem. It is the number one problem that is brought to the clinics by women. So that's interesting in and of itself, that somehow it's the one thing that allows women to get out of the house. And that was very important to us as we were focusing our project. The second element of this is that our work prior to the development of intervention showed us that there was a significant relationship between gender inequity, financial issues, intimate partner violence, marital conflict, forced sex, and Safed Pani. And also that Safed Pani and those negative life situations were related to women's risk, particularly focused on husbands' extramarital sex. Also, Safed Pani was an indicator of psychological well-being. And finally, as women came into the clinic, this is the governmental allopathic clinic, we were able to engage them into an intervention. So it took a while, but Safed Pani became a key concept for us. Tension was another development, and Safed Pani has been around and the concept for 100 years. Tension is really a development in the last 10 or so years. And it really is a transliteration of into South Asian languages of the English word tension. But it's like a gift to interventionists. If you can, having identified it, it provides the ability to refer to mental health through the concept of tension, rather than dealing with it from the Western point of view, which would put off many Indian women and others who see mental and physical health as very much integrated and not separate concepts. So tension became a resource. Then you remember those Ayush providers that we were talking about. Those are individuals who are criticized as quacks outside the community, may or may not have very much training, may have been medics in the Indian Army, but they're the ones that we estimated that they're providing 10 times the number of daily visits for healthcare that were characteristic of the community, as opposed to that governmental clinic. So these individuals are seen as family doctors. They're very much dependent, residents are dependent on it. They're available right on the same block as the individuals in the community. And they're very much open to training. And so they represent an important resource. The allopathic clinic was very dismissive of Safed Pani. They were almost completely focused on maternal and child health. So it involved mainly women bringing in their children and not much other care for the women themselves. There was limited time. Every time 80% of the women were treated for STIs. When they announced when they presented Safed Pani, and we documented that of those first 250 individuals that reported Safed Pani, only one had gonorrhea. And so the antibiotics were way overused. But they also were willing to consider new approaches. And those new approaches developed into an implementation of a men's health clinic. Interestingly, I'll mention this a little bit later, but interestingly, when it came to HIV, men were not interested. What were they interested in? A whole cluster of symptoms called Gupta Rog, or secret illnesses, that had primarily to do with performance. And we could link performance to HIV. And then the development of a women's health clinic. Now, why would you need a women's health clinic in what is essentially a maternal and child health clinic? It's because nobody was paying very much attention to the woman herself. And so both of these represented very significant resources for us. Then we had the development over the last 30, 40 years of community-based organizations. And over the last, since it started, a large march for International Women's Day and other significant events in women's lives. And this presented the opportunity to utilize these resources for addressing gender inequity. And street drama has become a way of communicating to the community. And here you see this man has come back to his house drunk, and has was forcing himself on his wife, and they're interacting, and you can see a rapt audience. And we did this multiple times in the community. Imams were an important aspect. 80% of the individuals in this community were Muslim. There were 48 mosques. We estimated that on a Friday service, the major service in the week, there were 20,000 men, and this provided an opportunity for those imams to, they do a takrir, or a sermon, more or less, and the focus of those sermons were on gender equity, husband-wife relationships that had a significant impact on the men in the community. So let's see, I'm going to check my time. The ability to take all this information and organize it is certainly not easy. And in an effort to standardize this, I've come up with what I've called systems analysis. I probably would change it because systems have come to mean other things, but for the moment, we're looking at filling up these cells with the information that's been collected about culture and about cultural variation, both on the independent side, those causal factors, as well as the resources you're going to use to address those factors. Looking at that in multiple levels, for the moment, I've just indicated that as population, the residents of a particular community, and organization as a kind of institutions, government, national systems, media, and then asking a series of questions that can bring those resources together with particular independent variables. So for example, the first of these, and can I move the cursor? Can you see the cursor? Doesn't matter. Whoops, I didn't mean to go back. So the first of these is, how can the organization meet population needs? That's A on those. And that's our standard question. We're the deliverers, they're the recipients, and we're going to find out what resources of our organization or others that we can deliver to the community. The second question, though, is dependent on an understanding that it's the organization, whether it's my own or others, whether it's government or non-government, that are themselves contributing to the problem. And that's B. How can organizational resources meet organizational independent variables? Then C is in the realm of self-help. What can population resources be brought to bear to address target population needs and those independent variables? And finally, and maybe the most innovative, is D, how can those resources in the target population address the problems at the organizational level? For example, I've worked with a number of different organizations to enhance the ability of family planning services to be put into communities and organized by community members when there is the inability to get these resources, family planning resources, whether condoms or pills or injectables, out to a community on a regular basis, on remote communities on a regular basis. So in effect, you're taking the resources of women organizing themselves at the population level to address the deficiencies of coverage of family planning services. So when we take a look at this program, what have we got? We've got the variables we're most concerned about: gender inequity, constrained roles for women at the community and organizational level, and on the individual population level, low self-esteem and empowerment, limited mobility, poor husband-wife communication, men's extramarital sex, and trying to bring to bear those resources of CBOs, imams, street drama, International Women's Day, and other events at the organizational level, and the concepts of safed pani and tension, of women's and men's clinics that would be attentive to the needs of each of those and not focused elsewhere, and the Ayush providers also being part of that process. So I won't make all the connections, but what you're looking at is the beginning of a way to match resource and independent variable. Now, what do you do with that match? Well, that's what you have to figure out, and that's what we had to figure out. How do you structure that program? How do you bring these resources to bear? Who are you collaborating with in the community? Will safed pani be understandable and acceptable as a diagnostic category in the allopathic clinic? Will imams actually support greater gender equity? And if there's variation, maybe you have to identify a subset of imams, and so on. All of these make for complex problems, but I think what this process does is begin to bring these resources and conceptual independent variables together to be looked at. So in some ways, it's like a kind of sin. If your spark plugs have too big a gap, you're not going to generate any power. If you can narrow that gap a little bit, you may come up with a whole series of ideas. So in effect, our intervention involved the recruitment of 1,125 women with safed pani and other characteristics. We did a randomized control design in which the experimental groups involved individual counseling to address a number of those empowerment and individual issues, communication issues, group couples counseling in which both husband and wife pairs were organized into groups, one set in which only women, one only men, and then coming together for 3 additional mixed gender sessions, and then a combination of both individual counseling and group couples intervention. This was combined with a range of effects on a range of activities in street drama and community-based activities and the takrit that imams were doing. And we found that that the individual counseling combination with the group couples was not necessary. It didn't add to that. There was an addition, but no synergistic effect. But both individual counseling and group couples counseling had very positive outcomes as compared to the control. And we also found very significant changes as compared to another similar community in terms of gender equity, with imams being the most gender inequitable, becoming the most gender equitable, and the general population making significant change as well. I may or may not have time for this, so I'm going to rush through it, but I'm just going to give you some examples. The Cuarentena is a 40-day period. Many cultures have this. In China, it's 30 days, in which women get a lot of support, are expected to rest postpartum, are told to avoid all kinds of activities, including washing their hair and going outside. So some of these are relatively benign, but it's lots of support. And understanding that whole cluster of behaviors that accompany the Cuarentena, we found that those in which the first generation that were practicing the Cuarentena had much better outcomes than the second and third generation, and so developed a Cuarentena-oriented program, not necessarily with relatives, for second and third generation Chicanas. Similarly, the Comadrona program in Hartford and Puerto Rican community built up the well-known concept of a traditional midwife who organized family, community, and services into a program that still continues 40 years from the time it started, to strengthen women's support systems, not to deliver perinatal care, but to do all the things associated with perinatal care that would enhance and getting young women into perinatal care, to enhance their outcomes. And this is finally an experience that this is a program that Jean Schensul, my wife, did, in which youth were attending in Hartford clubs and bars where drugs and alcohol were used. And in the process of, in those days it was called raves, now it's, there were other rap, poetry, spoken word activities, but all accompanied by alcohol and drugs. And so they developed an effort with youth performance artists committed to not having alcohol and drugs, but continuing the shows and productions that allowed youth to both seek safe entertainment as well as to avoid alcohol and drugs in the process. So in summary, I think I've now gone the better part of 45 minutes and look forward to your questions. I want to emphasize the fact that we very much use and depend on evidence-based interventions from other populations and extant theories, whether it's feminist theories or group process theories or solution-focused approach counseling or others. But we see that as raising important questions and structuring services in a complementary way to all this discussion of cultural resources. And so we're not throwing out that part. We're not entirely inductive in the process, but without considering the culture, we feel like we're not getting anywhere. And the second aspect of this is this makes these programs relevant. They have greater potential for sustainability beyond the limited project funding. And they very much enhance our ability to get communities engaged. And by engage, we mean as maximally as possible to engage them into the initial research questions, to the structure of the intervention, to the analysis of the data, to the presentation of the data to the community, and to, as a means of advocating outside the community for the resources necessary to address problems. So on that note, I'll stop and hope that this was helpful in the process of your thinking through the relationship of culture to educational outcomes or to communication outcomes. And I look forward to your comments.
Thank you for your presentation. We will now take the question from the audience. So please remember to ask your question in the Q&A feature. If you want to ask it directly, let us know so we can unmute your microphone. No question until now.
Well, I mean, Perhaps while we're waiting for our first question to appear, should it appear, I have a question actually, Stephen. I found that presentation very interesting. And I mean, one thing that really occurs to me, I mean, this is a bit orthogonal maybe to your own work here, but one problem that I'm really interested in is questions of science denialism. Right. I mean, and this is very relevant in the context, obviously, of COVID-19. And I think a lot of the approach to science denialism in education and science education, especially, is to kind of double down on traditional approaches. We need to do a better job of giving people appropriate science education. We need to kind of do more to help people understand scientific processes and things like this. But to my mind, this approach, I mean, it's not useless, but it seems to me to be blind to certain cultural factors. I mean, a lot of science denialism seems very much tied into participation in various kinds of communities. We could think of communities on the left that are opposing mainstream society in various ways, or communities on the right wing of the political spectrum as well. And it seems to me that if we don't account for these cultural factors, our intervention in science denialism is likely to be pretty ineffective. So, I mean, do you have any thoughts about that? Any thoughts about how we can kind of address the problem of science denialism and use, kind of come up with solutions that are a little bit more, that take stock of some of the factors that you were talking about in your presentation?
Yeah, that's very good, David. And in effect, if you, whether an anthropologist or an educationist or others, moving into and understanding the worldview, just another word anthropologists like, of, let's say it was North Dakota ranchers who were refusing to wear masks. And, but that's such a narrow piece of their overall culture. Where would we begin to find cultural resources that would be helpful? Would it be helpful to find out the fact that these are people very much committed to helping each other at times of emergency, just for an example, or very much committed to a particular kind of religion with a worldview that makes an effort to address community problems, or and so on. So I think what you're first of all very right. It's easy enough to say, well, those people are just ignorant, and all we need to do is to train them to understand science. Of course, we're learning rapidly that science is a process and frequently delivers the wrong messages, and maybe even that gets communicated, so that I would see the need, unless they're extremely right, or to begin to explore what their worldview is and find what I sometimes have called cultural hooks. What is it that we can pin on? You know, if we go in with an intervention that teaches people about science, it's like trying to cook something on Teflon. You know, it's just going to slide off. But if we grab onto something, religious conceptualization, mutual support, that rugged independence may even have an effect. Then you're beginning to do the work that I think is necessary. So I think that's an extremely good point.
So we have a comment. We have a comment here from Gilbert. I mean, Gilbert, would you like to ask a question of Stephen directly, or can we unmute Gilbert's microphone here? You're muted. It looks like, Gilbert.
Can I do that?
I think Angus may be able to. Let's see.
Work through that. I think it's Angus can can do it.
Hmm.
I think he's on mute.
Hi there.
Yeah,
I think
now he's off.
Gilbert is all ready. Go for it, please. Thank you.
Go ahead, Gilbert. You're unmuted now, it looks like.
Well, I hope it's. Maybe we can read the comment instead, or.
Sure. So Gilbert's remarks here in the comment, he says, interesting outcome of HIV studies and years of community intervention trying to cope with low efficiency of drugs and treatment, as well as social considerations for cultural strengths. Remember that drug efficiency, when available, are treatments dedicated almost only to privileged countries. Right. So, I mean, I think Gilbert is drawing our attention to the fact that, I guess, and I'm sure this is a problem that you're familiar with, Stephen, is that our, I think in the West tend to have a high-tech approach and a very strong belief, well, we have to have the drug treatment or the technological solution or whatever. And Gilbert seems to be resonating with some of your comments that perhaps alternative approaches are frequently better.
Let me just respond by saying that we just finished the 6-year project looking at ART, antiretroviral treatment adherence, among HIV positive men who consume alcohol. So this was a shift into the centers, into the ART treatment centers. And that's equally complex. So the nice thing about that is there's a wide income range because antiretroviral treatment is available free in India. There's very limited services. People have to line up for 2 hours to get a month's worth of medication, and they may see a social worker for a minute and probably limited other contact. And adherence is a very complicated factor, affected very much by socioeconomic status. So no matter where you go and what you do, you've got the same kind of set of problems, and we had to discover those very much and begin to look for cultural resources at the same time. So Gilbert is both, we were able to focus on that whole world of receiving treatment, and then found many of the same similar problems.
So guys, it looks like we have a question from Christopher up next. Christopher, would you like to ask your question live?
Sure. Can you hear me? Yeah, amazing. Okay. Yeah, hi. Thanks very much. Very interested to hear a talk that describes very well what the kinds of things that I've been working on for the last few years, at least here in Quebec, but in a context that's completely different. And I'm just wondering, I work in a medical faculty and teach medical students, public health students, and it's often, and working in the field as well on these situations, it's often complex and difficult to deal with the vision of what the medical personnel have of what we do as public health anthropologists or anthropologists doing public health. So I'm just wondering if you have any insight into how to integrate the perspectives that you talked about today into the broader medical culture in which this work takes place. Thanks.
Yeah, that's, as you know, this is a complex problem, but it's not any different from bringing HIV concern to a community, getting Ayush providers to begin to increase their capacity to deal with STIs, to get medical practitioners to recognize and not poo-poo folk illnesses. to those right-wing ranches in North Dakota. It's that need to not, and I'll give you the best example of all. Imagine going into those imams to begin to talk about gender equity. Well, it turns out it's not as difficult. It's just that nobody went to them before. So part of this is our fear. No, fear is not quite the word. Our anticipation of rejection. And if we can move into a greater understanding of their worldview, and for example, in that municipal health clinic, no physician wants to be there. They've taken primary care as their focus, but they don't want to be there because you are who you treat. And so it's a difficult community. They don't want to get out of the clinic. At the same time, they need all the help they can get. So it sometimes means that you've got to pick somebody or pick some bodies to begin to work with who are sometimes called in our world positive deviants. They understand the need. They're a more natural approach to understanding the need to integrate other kinds of perspectives and to begin to work with them as you expand. So there's no doubt that there are some practitioners who, or even some medical researchers who are difficult to work with, but you're always seeking that sector that might provide greater understanding. When we were working on Group Drug, the secret illnesses, and beginning to link for men and prevention, HIV, STI with their concerns about sexual performance, which was much more important to them, we had an overarching concept of sexual health that worked out very well. And that ability to integrate those was very effective for both a selected number initially of Ayush providers out in the community and a selected number of allopathic providers in the government clinic. So I guess we have to spend an equal amount of time on the medical people as we do in the community.
I would agree with you. That's very very true. Very I think very encouraging as well. I mean, it's something at least I think is looking more and more of interest to others at this point. In the past 10, 15, 20 years, things have shifted positively, I think.
Yes, I think things have changed in that realm, partly as a result of failures of medicine, and partly the nature of more social science and more public health training in medical schools.
Right. Thanks very much.
All right, folks. Well, I think we've come to the end of our scheduled time today. Stephen, thank you very, very much for being with us today on behalf of the CSLP. It was a very interesting talk, which I enjoyed and learned from myself. And many thanks to all of our audience members and for being here with us today as well.
I have few closing remarks to do. So do you hear me?
Absolutely, Mayra, okay. Go ahead.
So we have another speaker on April 28th. So if you want to hear her talk, it's Professor Bronwyn Lowe from McGill University. And the title of her talk is Ooh La La, Identities, Language, and Wellbeing Inside Youth Recording Studios. So really, thank you, Professor Schensul. It was really an enlightening and engaging presentation. So I wish you all a great day.
Well, thank you all for inviting me, and feel free to drop me an email with any specific comments.
Perfect then. Thank you.
Thanks again.
Thanks, Stephen.
Bye-bye now.